So good afternoon, everyone. My name is Dr. Camille Clare. I also have my colleagues, Dr. Melanie Baldwin and Dr. Bronson Tucker Edmonds, who will be joining us today talking about faculty development on the creation of an anti-racism curriculum. We were fortunate to receive the Med-Ed grant this year, so look forward to this is the start of our programming, which we will be doing for the next 18 months or so. So this is, I call it sort of day one or step one, introducing you to this content and this curriculum. So we have no disclosures relevant to this presentation. So I think we'll start, obviously, if we were together, we'd allow for introductions, but if you can go ahead and start to put who you are in the chat and your roles, that would be helpful so we can get a sense of who is in the Zoom room with us. So obviously, many of us have probably seen this, this infographic created by Dr. Andrew Ibrahim, thinking about where are you on the anti-racism journey. So this is a continuum that many of us are familiar with. And so as you think about your beginnings of this journey, it's good to kind of get a sense, are you in the fear zone, learning zone, growth zone? And if you read the descriptions, you can kind of see where you are in the journey and what it will take to get there. So if we think about some of the challenges along this road, we initially attempted to do a poll, but if you could go ahead and think about putting some of your comments in the chat of those of you, I apologize, sorry. Okay, one more time there. For those of you who have either started the journey or thinking about it, what this looks like, it would be helpful to go ahead and put those challenges in the chat so we can kind of see at what point we are in the discussion, and that would be helpful. And we'll hopefully address it as we speak going along the way. Some of the challenges that I may have seen is such things as buy-in. I've heard from individuals as we've interacted on the WUVA platform this week. But if you have any other challenges that you may have faced, please let us know. We'll hopefully try to address those as we go along. So this is where what we hope to do in defining terms of diversity, equity, and inclusion. Diversity sort of gives us a sense of all of our individual differences based on multiple self-identities, sort of being asked to the party. Equity is the utopia where we hope to get to promote justice and fairness within the processes. So again, being asked what is your, asked to dance. And inclusion is ensuring that diverse individuals can participate in every level of the organization. So being asked sort of to play your favorite song. And belonging, which is a concept that we also think about too, is how can we be able to play, the music choice that we wish along our way in this journey. So just to define, which probably we should have done from the beginning, when we think about what it means to be an anti-racist, and Dr. Marsh gave a really excellent presentation and historical background earlier in her plenary today. Being an anti-racist, again, is a process of really actively identifying and opposing racism. It's rooted in being action-oriented to eliminate racism. Very often we think about the individual level, but what's even more important is the institutional and the structural levels in which we work. And so this approach that we hope to discuss and figure out how to get to is thinking about all these different levels and what steps we need to do to reach those. So in becoming an anti-racism, again, we must really think about creating an equal society, being committed to making unbiased choices, and really being anti-racist in all of the aspects of our lives, not just our professional lives, but also our personal lives as well. So our objectives today is we hope to think about what are some educational techniques for faculty development in this area, think about some opportunities and barriers to using such techniques, and also discuss faculty role modeling in this anti-racism framework, which we propose. So our next question for us to put in the chat or think about are, what are your institution's biggest challenges along this anti-racism journey? Feel free to, again, put your comments in the chat. So again, we can hopefully address those and figure out some limitations and challenges that you've had along this part of your journey. So this is quite a busy slide, but it really sort of lays the framework. And again, Dr. Marsh gave a really good background and historical perspective, and we could spend a whole session thinking about the aspects of how interconnected our historical background, structural racism, where it comes from, and really the assumptions. So it's sort of like my colleague always tells us, it's a chicken and egg phenomenon. Which came first? Do we have these assumptions that led to these historical policies and practices that ultimately led to differences in outcomes and racial disparities? Or did our history really predispose us and lead us to these inequities? So in thinking about the dominant narratives in which we live, this again really lays a framework for many of our thoughts. And I think at this point, I will turn it over to Dr. Baldwin to keep us going along this discussion.
Thank you. So now that we've clarified definitions and background, I want to transition to how this impacts us as educators. Many of our institutions have made outstanding strides in educating our students in the subject matter that Dr. Claire just reviewed, such as implicit bias, historical and current policies that embody structural and institutional racism, and health disparities. But unfortunately, that leaves a gap between the knowledge base that our learners have in this subject matter compared to our faculty, and it's critical to work toward narrowing this gap for the sake of ourselves and our learners. And so this is a really powerful definition of anti-racist pedagogy that I wanted to share with you all as we talk about developing anti-racist educators. Anti-racist pedagogy is not a prescribed method that can be simply applied to our teaching, nor does it end with incorporating racial content into courses, but it is an intentional and strategic organizing effort in which we incorporate anti-racist approaches into our teaching, as well as apply anti-racist values into our various spheres of influence. And it requires our humility, our cultural reflection of our social position, and commitment as we confront our internalized racial oppression or superiority and how those things impact our teaching, research, and work. And so according to this definition, which I wholeheartedly agree with, we can't truly be anti-racist educators without the crucial self-work of humility and reflection on our own experiences and perspectives and how we bring these to our work as physicians and as educators. Next slide. So now, presuming we've done our self-work, we've reflected on our perspectives, we are aware of our biases, how do we as education leaders incorporate this into our teaching? And how do we apply these practical principles to things that we can share with our colleagues as we're working on their development in this space as well? And so first is incorporating racial issues. So one example of how this has been done quite successfully has been the teaching of J. Marion Sims as the father of modern gynecology. And so rather than focusing just on the medical achievements of pioneering GYN surgical techniques, as I was taught as a medical student, it is much more commonly taught lately that these techniques were developed within the context of slavery on unanesthetized enslaved women. Another example of this is the incorporation of racial and ethnic disparities in talks on a particular subject, such as maternal mortality or postpartum hemorrhage or cervical cancer. Next is challenging assumptions and fostering critical analytical skills. So this is encouraging our students to challenge the objectivity of what we know and the process of knowledge production. Another more recent example of this is the teaching of the use of Henrietta Lacks cells in research and gaining an understanding for our students that the creation of knowledge is not inherently unbiased and just. Having learners take responsibility for their own learning. So this is a move toward decentering authority in the classroom and power sharing between students and faculty. One of the things that we use in our clerkship is the flipped classroom model for case-based learning, where we have students leading the case-based discussion, and the faculty are there to provide some guidance and some wisdom. Next is empowering learners to apply theory to practice. So we move beyond just banking knowledge to the application of knowledge. So when we teach something like social determinants of health, students take the next step to operationalize that knowledge by discussing what we need to practically do in taking care of a patient that may be uninsured, for example, or unhoused. And then lastly, fostering community through collaborative learning. This means that we as the educators have to create a trusting learning environment where everyone is invested in working together for the sake of everyone's learning in the room. So how do we apply this? Now that we've laid out, I'm sorry, next slide.
You're there.
Thank you. So now that we've laid out what it looks like to be an anti-racist educator, how do we apply this to faculty development? How do we create content to meet our faculty's needs, which can widely vary in becoming anti-racist educators and leaders? And so we've divided this into 3 levels. So first, the individual level, where we're dealing with knowledge and behaviors. So this would be having a foundational understanding of topics like racism, microaggressions, privilege, social determinants of health, seeking and learning about the perspectives and experiences of others. By improving our own understanding of these concepts, it improves the experiences of both our patients and our learners, and it starts us on the path that we need in order to have that critical self-reflection that allows us to be anti-racist in our teaching. Next is education and modeling. So as we discussed, how do we incorporate racial and ethnic disparities in OBGYN into our lectures or education sessions? Adding upstander or bystander training on what to do when we witness racism or discrimination. Creating inclusive and anti-racist curricula for our students and our residents. Also incorporating these concepts into our research agendas. And this serves as a model for those that we mentor within the research setting. And lastly, there's the institutional level and how we incorporate these things in our institutional leadership. And that includes things like recruitment and retention practices for both faculty and learners, formal mentorship initiatives, as well as faculty development initiatives. Next slide. So before we move on to our activity, I just want to more broadly apply this to the scope of what we do as academic OBGYNs. First and foremost, we teach, and so we serve as both UME and GME educators. We provide top-notch evidence-based clinical care in a variety of different settings. We continue to do research to pursue innovation in our field. And then last but not least, we serve as advocates for our patients and communities that are at the center of our academic mission. And the important thing to note is that there are ways to incorporate anti-racism into each and every one of those aspects of what we do, and to serve as teachers and role models while we do it. So since you're all experts now, let's get to work. Next slide. So you all are going to be divided into small groups of 4, and you'll be assigned a specific challenge to address. And in the chat, we've posted a Google Doc, which has 2 different scenarios. Each group, you'll either be assigned case A or case B. And so based on your group assignment, you're going to look at the challenge that's there, and then following the guidance of the handout, work through the process of developing an intervention for faculty development that meets the need identified by that challenge. And in the handout, you'll see that there are some guiding questions, which I want to talk through a little bit, as well as some resources for you. So as far as those questions go, let me just pull them up. So first, as far as the response to the challenge, is this intervention grounded in a culturally competent approach? And so this means, are we being inclusive of different cultural backgrounds, experiences, using inclusive language? Number two, how does this build power on the margins? As we discussed, decentralizing power in anti-racist pedagogy, how do we share power within the group? How do we amplify power for groups that have historically not had it? Number three, does it encourage collaborative and collective thinking? And then lastly, number four, how does this illuminate the institutional, cultural, and personal aspects of the challenge? And again, those questions are in response to the kind of intervention that you develop. And so we'll give you all about 15 minutes to work through your scenario. And then once you're done, each group is going to report back to us, the larger group, about their experience with that. Now, we know that it takes months to develop an intervention like this usually, and you all have 15 minutes. So if you don't have a perfect product, that's fine. I think it is just as valid for us to talk through the process of coming up with the intervention as it is to discuss the product that you come up with. All right, we will see you after your groups.
Welcome back, everyone. I think we should have we all got pushed back into the room. So I think we should have everyone with us at this point in time. And we're really looking forward to hearing some report outs from the time that you spent together. If you're like me, maybe because I'm a person who talks a lot, the time is never long enough. So, we're gonna just assume that you didn't have enough time to like solve world peace and fix our broken system. We're gonna assume that. That said, we are still really excited to hear about what you did come up with and some of the dialogue that you shared, even some of the sort of complexity or concerns that were raised in the course of your discussions. We'd like to sort of open up the floor, really just to hear from you in terms of your thought process and any solutions that you did come up with so that we can begin to do that learning together. We also wanted to just underscore that it's not like there's one right answer. So we don't have an answer key over here that we're waiting to see if you sort of are going to get it right. We really are here to learn together and to sort of continue to kind of cultivate, kind of build the muscle to try to do some of the sort of difficult work and of doing the best that we can in circumstances where there may not be one right way. But we're hoping that we can do some learning together with the remainder of our time. So I'll stop there and maybe just invite our group one, if there's someone who does like to talk and do the report outs. There's usually at least one person in the group who's willing to kind of share with us what you came up in response to our prompts.
So I was with group one. You can see both me and Kathy Jorda. My name's Ian Fields. This is Kathy Jorda. We're some program leadership out at OHSU in Portland, Oregon. So thank you for giving us the opportunity to talk about this. It generated a really nice discussion and we came up with some questions too. So our scenario involved a Latinx medical student who was asked to take out the trash when they were in a patient room. And so we were asked to sort of create some type of toolkit or way to help develop ways to address microaggressions as they occur, especially with learners on the service. And so one of the things that we talked about was really aimed at mostly faculty development and how we could give them a toolkit on how to go about addressing these, but also giving faculty the opportunity to practice that in a safer space. So doing some role play things and giving them examples of what microaggressions might be, because some of them may not be aware of what those might be, and then to also give them the opportunity to debrief this. So not only how to address this in the room as this happens, but also to provide a safe space with the team to debrief not only with the team that's there, but also with the medical student involved, and to sort of give them the power to be involved in that patient's care moving forward or not. one of the big questions that came up is whether or not we should address the microaggression with the patient themselves afterwards. And there was some discussion about whether or not that should happen, whether or not that was an appropriate thing to do. And so I guess we would just open that up to discussion with the group.
Thanks for that. Thanks for sharing those comments and reflections with us, Ian. I'm sure that there will be more thoughts to add to that. What we'll do is go ahead and let group 3, since you guys have the same case, sort of report out a little bit about the things that came up in your discussion, and then we'll sort of come back and try to bring some of that together.
So I can speak, although I did note Jennifer just demuted herself, so you can feel free to chime in, but I'm Laura Bater-Lind, and Jennifer and I were in the same group together. So we also kind of both shared experiences that we had both been through fairly recently that were similar to this example. Both were a little bit different in that they were patients who refused to involve learners in their care and were overtly racist in making and gender biased in making those requests and how we handled those. I think we struggled a little bit more. This is, we weren't in the room for this example, whereas the ones that we shared in our group, we were there. And I think it sounds like group 1 also kind of struggled with what do you do now that the student has already left the room and going back and bringing that up with the patient. And also how important it is to have, a patient, not the Bill of Rights, but the inverse side, the provider Bill of Rights. What is it that a patient owes to their healthcare team? Because that really helps to facilitate some of these conversations with the patient, where you can be empowered to say, no, actually, you do need to treat your team with this respect, and that is part of the contract of getting your care here at this institution X, and how both of our institutions and our group were on different trajectories towards getting those kinds of protections in place, which really help us to have those conversations with our patients.
Yeah, so for next steps, we talked a fair bit. I told Laura that I had actually just been through a training about sort of our newer, it's not called the Provider Bill of Rights, but it's something similar that actually denotes that our institution will not stand for any discrimination, race, sex, gender, ethnicity, country of origin, any of those protected classes from patients towards providers or any member of the care team as well. And so we actually just had faculty training around this and sort of how to deal with it from the top down, which was great. So really, I would just like to copy that. It was beautiful. There was a lot of play acting and a lot of sort of getting comfortable being uncomfortable, because most of these conversations, no matter how they're going to come up, they're uncomfortable. And it was literally the day after my seminar that I had the most recent experience with somebody being very overtly having gender bias against one of my residents, and still very uncomfortable, still turned very red, but had a very hard conversation with her. And we got to a place where she was happy with her care, but that she was also being a little bit more reflective of her preferences, and was able to say, you're right. Okay, so I really just mean for X, Y, and Z, sensitive portions, whatever, everything else is fine. But we're able to have a little bit more of an open dialogue. So I think just refreshing faculty's knowledge on their rights, on sort of our responsibilities also to our learners and to every member of our team in terms of protecting, and also going through some of those microaggressions. I think identifying them as microaggressions is step 1. So if you can't do that, we're not going to make it very far in the rest of the conversation. So I think that was certainly a very important part of the training as well.
Thank you all so much. While you were talking, Dr. Dury, I just added the scenario to the chat for anybody who might have come in after the Google link was placed in there, so that you could have a chance to kind of catch up. So our first 2 groups, or 2 of our groups, they were addressing this particular case that I just put in the chat. And you guys have gotten to hear a little bit about sort of their thought process and some of the things that came up for them. It sounds like this issue around sort of recognizing microaggressions came up in both spaces, providing opportunities and mechanisms to kind of practice what I'm going to term as like upstander or kind of bystander kinds of skills came up. Having tools, toolkits in terms of kind of how to increase or enhance one's like knowledge base, as well as actually like skills to be able to kind of act in the moment. And then also tools for debrief, it sounds like came up. And then looking to sort of institutional, be it policies, related to what the rights and protections are, not only for patients, but also for providers to be able to provide care and learn in terms of our learners in an environment that's safe. Those are the things that kind of I heard and wanted to kind of reflect back to the group to sort of tee up this conversation. But I'd love to hear if other people had sort of observations that they saw in terms of similarities between kind of what was shared between the groups, or kind of additional complexities that you feel like are worth naming and speaking to. The other piece that said is this question about whether to go back kind of after the fact and address this. It sounds like that was a point of discomfort for both groups. So I'm going to just leave it there and open it for you all to deliberate a little bit amongst yourselves.
One question that I would also pose to you all is, I think that in this bubble of people that are very interested in learning about this topic, we all are starting from a place of, well, of course, our faculty want to learn these things and not perpetuate harm. I think we should also be thoughtful that there are faculty that may or may not understand microaggressions, may or may not understand their impact, may or may not believe that they are a real thing, because that is a belief kind of in the larger society, and we'd be naive to assume that we don't have colleagues that may feel that way as well. So starting from a place of how do we get buy-in from faculty that this is a real thing that we need to be able to advocate on behalf of our learners? What are some thoughts as far as that very initial step, if buy-in is a challenge?
Please go ahead, Sue.
Okay, so I don't know whether the students in Texas are just a lot different than everywhere else, but our students call us on the carpet on it all the time. So they force us to buy into addressing the issues.
I also feel like in thinking about this case now with the bigger group, it sounds like she's come to, you're the clerkship director. I think I kind of missed that part. I was thinking of myself as the attending. So in a sense, what the final sentence is that no one spoke up or said anything. That might have been the most hurtful aspect of this whole thing, right? It sounds like she tried to speak up for herself. And we did talk, Jennifer and I, about like kind of power differentials between attendings, residents, students. It sounds like there were other team members in the room that should have spoken up for her, if not at least echoed what she was saying. And so I think that seems to be, in maybe not going back and speaking with the patient wouldn't have been the solution, but going back and speaking with the medical team and just saying, hey, you should have had her back, would have been helpful.
I agree, or even just trying to find out why they didn't speak up. Perhaps they also felt similarly perceived by the patient, or they were frightened of the situation, or they had never been in a situation like that. So I agree with you completely. I think this is a really great educational opportunity to bring that team together, in kind of a comfortable setting and just talk through the whole situation. Like, what was everyone feeling? Did y'all feel like what happened was wrong? And if so, why? And what are some of the ways we could handle that? And how might we handle that in the future if we recognize it? Because I think for some students, they may recognize, a microaggression, but then not really know exactly what to do with it. And so I think by the clerkship director taking the opportunity to sit down and review that with the team, it sort of empowers them to take action next time in a positive way.
I think we're very familiar in a clinical scenario when outcomes are not as we expect, the debrief process, right? You had postpartum hemorrhage and we all are comfortable in debriefing. So I think coming to a place where these kind of circumstances allow for these debriefing episodes are really helpful, I think, for the team and for future identification and maybe how to manage it, right? You may not have remembered to put the battery balloon or had it available, but next time you'll have it on the floor or whatever. So similar thoughts, right?
I'll just add one more point to it, and then we'll move to our next case, not because there's not a lot more we could talk about with this, but because we are constrained by time. But the one other thing that I think is so important, just to kind of pull together a couple of the different comments, the fact that I could imagine that you might have someone sort of see this and not really think, like, what's the big deal? So we talk about the notion of like, how do you recognize, how do you know, is it really a harm? And I think that there's a way like, oh, you could take take it out, keep it moving kind of thing. We all get asked to do things and that kind of thing. So that's like that could be a very legitimate perspective. It's like, was it entirely harmful? Was the patient trying to do harm, or did they just kind of have a but I think what's really key here is that the student clearly was like trying to express that wasn't their role, that wasn't, and that they didn't have anyone having their back. I think that's what I hear is sort of coming to a head, and then that's being positioned. So I think that these tools that you talked about taking that back to the team, so that there can be, like, in no uncertain terms, right, that the reason that it was a question is because the person actually experienced it as microaggressive and as belittling, or sort of like lessening, right, of their kind of value and standing on the team, and that in and of itself is reason for us to take seriously how we might attend to that differently moving forward. So I don't know, that's just one thing that sort of stood out as you guys were commenting and kind of unpacking it a little, that there's that this is a real opportunity, particularly because it clearly had an impact that the student clearly experienced it as microaggressive. And we have to remember with microaggressions that it's not about intent. So whether the patient was intending that to be the impact or not, that wasn't clearly the impact. So I'm going to move us to our second piece because we got to keep moving. But thank you guys for sharing and for doing sort of that thought work together. The next case we had for groups 2 and groups 4. So do we have a volunteer from group 2 to share what you came up with?
I'm not sure which group we were. I didn't see the number.
Oh dear. Well, someone who did scenario B, one of the people who haven't talked yet. Here's your scenario.
Robert, go ahead. I think it was us. I think we were 2. So if you want to go.
So we had basically an intervention to reduce implicit bias in the residency, both selection and the program itself, and tried to find ways that we might be able to do that. And the first thing we went was right at the beginning. One of the discussion points was possibly eliminating identifiers like name and pictures when first looking at an application, particularly with the step 1 scores going away, goes to pass fail, and then you have to look more at the meat of it. You can't be swayed by a picture or a name or anything like that one way or the other. You have to look more on the merits of that. And then also the question is how to take, I guess I was put as the marginalized groups in there, and perhaps expanding the role of how people are selected. Discussion, like currently applications are reviewed by a select few and then brought to whatever committee does it afterwards after interviews and stuff. So maybe expand the people who are interviewing, or not interviewing, but reviewing applications to say, hey, I like this one, or hey, I like this one. So any one person's implicit biases would be minimalized in that aspect. And then there was a question of whether or not to include, interprofessional, PAs, nursing leadership, even going out to, if you're involved in community boards, to bring them in, or perhaps past alumni. But I'm not sure on that one. I just on my own, and this wasn't the group, where I felt like that almost propagate more than, that's, I guess, if you have a lot of alumni and, they are diverse and you lost your diversity, then maybe you want to go back and get them. But if you don't have a lot of diversity, I don't know if that would help. So that one I was thinking, not good enough for my program, too small of a program, too recent. But bigger programs, that's an area I don't have experience with. Sarah, you got anything else to add on that?
No, that was great. We actually had such a good discussion. I think the time felt really short. But I think the only other thing to add was just the potential use of community providers too, that have regular interactions with the patient population throughout your community. And especially if a lot of your graduates tend to stay in the community, they may have a good hold on, what type of applicants may fit best and serve the community best, and the types of backgrounds, activities, things that might align best with your community. So that might be another thought.
Thank you all so much. Those are really great suggestions. I will refrain from commenting further on them until we hear from our other group, and then we'll bring that back for further discussion. So I believe it was group 4 who also had scenario B. You want to report out anyone?
Sure. So Courtney and I were in group 4 with Melody, and we took less of the kind of applicant process and the whole process as a whole, starting with how you present yourself to applicants. What does your website look like? Frankly, what does your faculty look like? Can you be somehow involved as a residency or clerkship leader in helping to recruit diverse faculty to, which would then help bring in diversity to your residency? Then we talked a little bit about the holistic review process and getting rid of scores and things like that. But then also once you start to interview, how you decide who to interview, how you present yourself during interviews, how you then submit your rank list, what your rank list looks like at the end. And then once residents arrive, what you do to support those residents while they're there, because if they have a negative experience, then they'll report back to applicants that, this is not a supportive environment. And, part of that includes getting your faculty on board with your vision of the holistic review process and how you are going to recruit. And that probably has to start first and foremost. I didn't know if you had anything else you wanted to add, Courtney or Melody.
I think you kind of hit the nail on the head there, Christine.
Really, really rich discussion, it sounds like, and really fantastic suggestions and ideas that I feel like were put forward. And I liked that it was not only, sort of with a focus, I thought some innovative focus with regards to the application process itself, but then with our second group also really thinking beyond the scope of sort of the interview process to kind of where the conversation even starts. And then once you have those applicants matriculate, how are we supporting them in terms of the ripple effect for how those experiences then propagate in terms of sort of future standing with candidates in subsequent seasons of interviews and applications. So you guys put a lot out there for us to think on. I want to open it up for people to comment or ask questions or add additional thoughts to it. And we're going to do that for just about another 5 minutes and then kind of wrap up with some closing thoughts and resources that we have coming your way. So let's hear from folks in terms of reactions to group 2 and 4's report out. Anything come as a surprise, something you hadn't really thought about, something that you wanted to hear more about in terms of what was being suggested? I'll say for when I hadn't heard about folks really thinking intentionally about those community providers or community members being engaged in the process. And I think that the metrics that we would look to, the number of kind of research experiences and things like that we've historically decided made people more or less competitive might fare really differently in terms of the relevant importance to community members or community providers and things like that. So I think it's an interesting idea because by virtue of sort of democratizing that selection process, it might also have implications for even what we decide is really kind of important in our, or sort of prioritize more salient in our criteria for scoring. So that's interesting in and of itself, but other thoughts on that?
I didn't have any major thoughts. Just looking through this case just made me think, what's the why? I mean, you clearly didn't have a problem before, and then all of a sudden you have a problem. So just really thinking about the whys. And I think that's what group 2 really kind of was alluding to. And then that would help facilitate your change. Was there something major that changed? Was there a leadership change a few years ago where now applicants don't feel supported? I feel like it'd be a big deep dive into why now you've all of a sudden changed from a diverse group of people to not. seem like a big thing to focus on, and that would just drive what you would change in your program. But I thought that was great. Great discussions.
Sue, just to respond to your question in the chat, does anyone have a program that they've developed to train the residents and faculty on bias? So one thing that we did for our residency interviews this year is I recorded I'm a member of our diversity and inclusion committee. I recorded a pre-interview lecture for the interviewers, the faculty interviewers, to watch before they started their interview day, and it was required of all of the interviewers to watch it before their sessions. And it focused on implicit bias. We also talked about kind of how we represent diversity and inclusion in our department, giving them the talking points, because I think part of what we realized is that more applicants are looking for D&I efforts from the programs that they're applying to. And so, for different faculty that may not be aware of what we do, just to educate them on what already exists. So it's not something that they necessarily have to be responsible for creating programs or whatnot, but they at least are aware and able to have a conversation of the things that our department does and the initiatives and kind of the beliefs of our department and values. Also kind of a little bit about the city of Durham, which is a diverse city with multiple ethnicities. We have lots of immigrant communities here, and just to make sure that faculty are aware of what exists in our community. And then lastly, some very handy, just do's and don'ts, talking about pronouns, talking about pregnancy. Do I bring up race? If the essay mentions a same-sex partner, do I bring that up? Just like some things that made it easier for the interviewers to conduct an interview that was safer for our applicants and made them feel supported in their own identities, whatever those were. As far as did it work, I think the feedback that we got was the faculty felt a lot less intimidated. I think they walked into this interview season scared that they were going to say the wrong thing, scared that they were going to mess something up and offend somebody or not know something. And so I think kind of, with the cliche knowledge is power, I think they felt less intimidated by going into the process and being more prepared with actual things to do and words to use.
That is really fantastic, Dr. Baldwin. I know people are going to be following up with you to ask if you could share that. And it's a really nice segue. We're kind of in sort of winding down in our session. So I'm going to kind of hand the baton, but it's a really nice segue to start to think about what are sort of the tools. We started the conversation about toolkits and things that folks can have to really help to build skills and knowledge among our faculty and to sort of inform our kind of policies, practices, whether folks have already here mentioned some things that are going on at their institution. So I'll hand the baton back over. Well, I see that Dr. Claire's mic is off, but I didn't know if you wanted to sort of close us out, or Melody, in terms of sort of giving people a little bit of a sense of coming soon to a theater near you in terms of sort of next steps that we are in the midst of planning as a group. So I'll stop there and you guys can close us out.
Sure. Thank you so much for that excellent facilitation, Dr. Tucker Edmonds. Obviously, always a value and really great to hear everyone's perspective. So, we did debrief the activity a little bit. I think from a summary perspective, we know that anti-racism, again, in medicine is the active opposition of racism, racist structures, policies, and our practices, the relationship to our communities, which was really emphasized in our discussion this afternoon, which really impacts the education of our learners. So curriculum development does require a sort of a needs assessment as you think about your own departments and your institutions to identify what your goals are and how to incorporate this pedagogy into your thoughts that is anti-racist in focus. And these do come with challenges, as we've recognized. They're inevitable, but it's rewarding in the end. We look forward to you hearing about several things that we're doing in this 18-month period of time, which includes webinar development, as well as curated resources and content to help you on this journey. So more to come in the future, which will be housed at APGO. And so we really appreciate the opportunity to talk to you about that. And I think with that, we have a few minutes or so for about 2 minutes or less for a question. If anyone had any additional thoughts and concerns and questions that they want to provide for the group. So thank you for this opportunity to share our thoughts with you all this afternoon. All right, thank you all for the kudos in the chat. And if anyone, I'll put my contact information in the chat as well, my email, and feel free to reach out to us in the future. So if you have any questions, I'm sure Dr. Baldwin will be happy to share her resources and her materials from what she's done at her institution. And that would be great. So thank you all.
I'll have
Thank you. Take care.
Be well.